All right, everybody. We're going to go ahead and get started, and this is lecture number 1. We are going to be discussing advanced cardiac assessment, and we're going to do a brief overview of hemodynamic monitoring. And you're going to see tons and tons of hemodynamic properties and principles at work in both the ICU and the ER. Predominantly, you'll see the concentration of being able to assess these numbers, interventions for these numbers. You'll see the bulk of that in the ICU. Without talking too much more, let's go ahead and get started. Okay, I am not going to cover the objectives. You're more than welcome to go ahead and read through them if you'd like. I will say these are italicized for a very, very clear reason. I strongly recommend spending some time knowing preload, afterload, and contractility. These are concepts you already should know by this point in the course, by this point in nursing school, but go ahead and refresh on them if you need to. Okay, we're going to be talking about some different concepts here. We're going to be talking about right arterial pressures. We're going to be talking about pulmonary artery pressures themselves. And this one right here is a very important one we're also going to discuss. It's pulmonary artery occlusion pressure, also known as a wedge pressure or pulmonary capillary wedge pressure. Okay. We're going to discuss cardiac output, cardiac index, how they kind of go hand in hand, how they can be reflective of one another, and some of the influencing factors and values of both. Systemic vascular resistance is a very important concept to understand. Pulmonary vascular resistance as well, essentially asserting that the resistance from the distal systems have an effect on a certain part of the body. For example, if you're hypertensive peripherally, let's say, in the periphery of the arteries, let's say you have some peripheral vascular resistance, you're going to have an increased pressure in your aorta, and you're going to have an increased pressure placed on that left ventricle. It's going to pump harder to overcome that increased systemic or peripheral vascular resistance. So more concepts to be sure of there. And then we're also going to discuss arterial lines, central lines, also known as CVPs. And then we're going to talk about Swan-Ganz catheters. So medications, and I'm going to be honest with you, for the next probably about 4 weeks, we're going to be discussing and have conversations surrounding these specific medication categories and classifications. We're going to talk about some pathomimetics. In case epinephrine is a perfect example, vasopressors, inotropic agents, volume expanders, beta blockers, calcium channel blockers, ACE and ARBs, diuretics, and vasodilators. Okay, all of these medications have properties that allow us to manipulate hemodynamic stability, hemodynamic excess or lack of volume in the case of volume expanders. There's a lot we can do, and I want to make sure that you guys understand that as we go through this. So let's keep going. Terms. You should definitely know these terms. Okay. You guys should already know stroke volume, preload, afterload, contractility, cardiac output, cardiac index. You should know body surface area, but we're going to explain a little bit more today. Pulmonary artery, the Swan-Ganz catheter concept is probably new. Transducers probably new. Pressure tubing, flush systems, and calibration. We will discuss all of that as well. You can read those. Tests we will be discussing. Allen's test, it's a very simple test. I'll show it to you. Arterial blood gases and why we do them. We're talking about CVCs, CMPs, electrolytes, coags, panels, and EKG monitoring as it pertains specifically to hemodynamic monitoring. So why do we do it? Just straight up, why? What is the purpose of hemodynamic monitoring? Okay, we can already monitor heart rate, we can already monitor blood pressure. Why do I need to go and do anything more? Well, hemodynamic monitoring is an incredibly useful tool, especially when it comes to the treatment of patients that are acutely ill, severely ill, especially in the states of like sepsis, anaphylaxis, any kind of like neurogenic shock, anything like cardiogenic shock, obstructive shocks, hypovolemic shock, pretty much your four main shocks. Hemodynamic monitoring is incredibly useful because it really allows us to manipulate blood values, volumes, and vasoconstrictive or dilative properties. And that's the only way we would get these numbers and know how to manipulate them is through hemodynamic monitoring, arterial lines, central lines, and in some instances, Swan-Ganz catheters. Okay, so this is continuous monitoring. This isn't I take a blood pressure Q4 hours and I won't go ahead and document it. Arterial lines, CVPs, and Swan-Ganz are second to second monitoring. They are active updates that let you know what's going on. If you ever see a question and it's like, hey, who would be most likely to have this? It would be someone who we're monitoring that is critically ill and needs to have active interventions, vasoactive interventions, or volume interventions, diuretic interventions, and we want to keep a really close or tight eye on that hemodynamic state. Okay. Anybody who has life-threatening conditions, heart failure, cardiac tamponade sepsis, the list honestly is monstrous. I could talk about it all day. We want to assess any responses, any kind of interventions all the time, every time. If you ever lay your hands on a patient and you assess, okay, and you discover, hey, there's a problem. Problem is A, B, C. Well, here's my interventions. Here's what I'm going to do for A, B, and C. You absolutely must document the results of A, B, and C's interventions. Okay, so keep that in the back of your mind, please. There's one golden rule. I really like it. I am 100% in agreement with it. And I think I've even shared with previous classes a story. And I have one I always go back to, but don't treat the monitor. Okay, and I know that might sound silly, and I'm sure most people called it silly until the nurse sees the monitor go flat while the patient is sleeping, goes into a systole, immediately hits the code blue button and starts compression, and forgets that all too important critical step of checking for a pulse. Okay, so it's easy to look at these numbers and it's easy to look at these monitors, and especially when they start making all these funky little noises and sounds, and you're sitting there staring at it and you're like, oh no, my patient's dying or is dead. Okay, look at the patient, look at their state. Bradycardia is a perfect example, hypotension, perfect example. In otherwise healthy patients, okay, that exist in states of persistent bradycardia or hypotension, if they are asymptomatic, is that something that's really hurting them? And that's a question you have to ask. And that's, again, this is a basic example. There's people that walk around with systolics in the 90s. Okay, there's people that are bradycardic in the 40s and 50s, and that's their persistent state. That's where they live. It's where their body's comfortable. Typically, there's a physiological reason, and in some instances, ideological reasons, but either way, don't treat just the numbers. Okay, they can be great guides, great indicators, knowing your blood pressure, knowing your pulse, knowing actively what's happening inside the patient's body based on trends. Uh, there's a lot of decisions that that can help us make, but that's where critical thinking comes into play. If all of my values say, oh my gosh, this patient has terrible perfusion, terrible hypotension, terrible bradycardia, and they're sitting there in bed, eating their fifth Big Mac and super happy, and they jump up out of bed and run to the bathroom and, yeah, hey, how are you today? That's not a symptomatic patient. Okay, so the numbers are great. Do we need them? Absolutely. Are they for a very specific population that we're treating typically in the ICU? Absolutely. But am I going to base my decisions purely off numbers? And the answer is absolutely not. Okay, so let's continue. Principles of monitoring. Yes, flow times resistance is once again going to return. Okay, so if I ever ask you what's the volume, or excuse me, how do you calculate pressure? It'd be force unit area flow times resistance. I am not going to ask you to calculate that. This is more of a conceptual thing I would like you to understand. Okay. Flow, volume of fluid movement per unit of time. Okay. And this is another example of flow. Okay. Would be we take a 60-second measurement of the flow or volume of blood out of the left ventricle or the heart. Okay. So if I say to you, what's your stroke volume? And we say an average stroke volume should be between about 60 to 70 mLs. Some books say up to 80. That's fine by me. And I say, well, what's your minute volume? I'm literally asking, what is the amount of volume coming out of the heart over 1 minute? Okay, well, how would you get that? Well, it's pretty easy. We are going to go ahead and assess stroke volume. Okay, and typically we do this with an echocardiogram. We go ahead and get that stroke volume and we just multiply it by how many times their heart beats in 1 minute, and boom, we can actually get our output, our minute volume. Okay. The concept of resistance is something that should be returning to you, should be a refresher. Okay, remember, the fluid flowing through the middle of a blood vessel is the freest moving, most quick moving fluid in the vessel. Okay, that would mean that the blood flow through the center of the vessel is moving faster than the exterior or the walls of the vessel because they apply back pressure on the blood flow. All right, so this kind of shows just a little bit of a basic principle here about that resistance and that pressure and flow. So we have obviously two blood vessels here, okay? And I know what they're really trying to assert here is we look at it, the radial diameter of 2 centimeters, Okay, there's radial diameter. Radius, excuse me, of 2 centimeters versus a blood vessel has a radius of 4 centimeters. Okay, obviously we look at the number and oh, we're just going to double blood flow, but that's not the case. Okay, I will never ask you guys to calculate based on diameter, radius, circumference, whatever the case may be of a vessel, how much blood flow you have. Just be aware of the concept that obviously if a blood vessel dilates, you will be able to move substantially more blood through. Just because a blood vessel dilates 2 times in radius does not mean we're going 2 times in blood flow or volume. It increases substantially. Again, I'm not going to ask you to understand that though, or not, sorry, not memorize this for testing. Understand the concept. I'm going to move past Ohm's law. If you want to memorize it, you're more than welcome. It's very simple. Okay. It's all the variables of driving pressure and resistance and effects on blood flow. Change in pressure different results in change of flow. For example, when you decrease our resistance peripherally, and I mentioned this earlier, less pressure is necessary to maintain the flow. So again, if my peripheral vascular resistance increases, my left ventricle is going to have to work harder and press against that resistance. Likewise, the opposite can be stated. So if my peripheral vascular resistance is decreased, my left ventricle will have less work. So anyway, you should already know the cardiac blood flow through the heart. Just a very quick refresher. Superior inferior vena cava, right atria. We're going to pass through the tricuspid valve. Everybody always gets confused here. Like, I can't remember which one's which. Well, you try before you buy. Okay, is the way I remember it. Tricuspid before you bicuspid. So we got a tricuspid down into the right ventricle, through the pulmonic valves or the semilunar valves into the pulmonary vasculature, specifically the pulmonary arteries. Okay, go out to the lungs, go into the capillary beds of the lungs, the alveoli. We exchange our gases, offload waste, onload oxygen, and back to the left atria via the pulmonary veins, both left and right. We're now in the left atrium. We'll move through the bicuspid or mitral valve into the left ventricle. And then we don't just go out the bottom of the heart. And I don't know why a lot of people think that, but we don't. It goes squeeze and out the aortic arch. You have our subclavian arteries here, out the aortic arch through the aortic valve right here. And then just a quick refresher, whenever this valve opens and pushes blood into the aorta from the left ventricle, we are actually closing off the coronary arteries that branch off the base of the aorta here. Okay. When this valve, after blood pumps out during systole, when the aortic valve closes, there's a degree of back pressure on the valve, and then it disperses blood out into the left and right coronary artery branches. So just keep that in mind. You should already know what your cardiac cycles are, diastole, systole. Okay. Diastole, we're filling. We're expanding the size and the amount of volume in both ventricles. During systole, we are emptying, we are contracting. This is the heart at peak work. Okay, and the easy way to remember it is that 120/80, that 120 systole, we're doing some work here, heavy lifting. Diastole, we're relaxing, refilling, resetting for the next work. Okay. Mitral and tricuspid valves are open during diastole. Aortic and pulmonic valves are closed. You must know that. Mitral and tricuspid valves are closed. Okay, so tri and bi are closed during systole. Aortic and pulmonic are open. So we have different factors in our body that control all these different vasoconstrictive or dilative properties or vasoactive properties. Okay, the bulk of which are going to be hormone driven, but we have different checks and balances, if you will. Okay, so you have baroreceptors that measure pressure, and chemoreceptors that measure your CO2 volumes, they measure O2 volumes, and the bulk of this is done in your brainstem. Okay, you also have the autonomic nervous system, your ANS, and your ANS, especially your SNS, okay, is responsible for vasoconstriction. Okay, whereas your PNS is typically responsible for vasodilation. Easy way to remember it is SNS is that fight or flight system. We're going to have that increased heart rate. We're going to be fighting back against a stressor, internal or external. Okay, increased heart rate, increased blood pressure initially, increased respiratory rate, bronchodilation, okay, and pupil dilation as well. So you're just getting ready for a fight. Your body's ramping up. Everything's getting tight. All right, blood vessels clamp down. They push more blood back to your core. They get you more heart flow. They get you more blood flow to your heart, your lungs, your brain, and your skeletal muscles and vital organs necessary to fight back or flight. So, and whereas your peripheral nervous system, your PNS, okay, the driving factor there is actually suppression of epinephrine, norepinephrine, and even dopamine, late stage, and activation of acetylcholine, and that's going to be where our vasodilation comes into play because our body's in a state of rest and digest. We are going to relax. Our heart rate's going to decrease, respiratory rate decrease, no bronchoconstriction necessarily, just relaxed bronchial muscle. Okay, we're going to see our blood push to our GI and renal systems because we're getting waste out of the body. We're breaking down foods. We're metabolizing. I need enzyme secretion. I need all sorts of stuff. Okay, so that's why after you eat a massive meal, you get super tired because you're not activating epinephrine and norepinephrine. You're relaxing. You're kicking back. You're hanging out. Your belly's full, and your body's like, "Hey, we need some help down here to digest all this." And they're like, "Okay, cool, thanks." We have our renin-angiotensin-aldosterone system. Okay, and I'd like to point out, or some people call it renin. That's fine too. Renin, angiotensin, aldosterone. Each one of these is a form of a vasoconstrictive property, okay, and with increasing intensity. And that's how this system works. Okay, so once we activate renin, okay, renin is going to result in a passive manner in the activation or secretion of angiotensin from angiotensin 1 to eventually angiotensin 2 and finally to aldosterone. And aldosterone is a very potent vasoconstrictor. I will point out these are all considered hormones. Okay. All right, here's one of those wink, wink, shooting star moments. You definitely need to know your cardiac output number. Okay, you must know cardiac output, heart rate times stroke volume. And I told you that earlier. It gives you your minute volume. If you didn't know what minute volume was, minute volume and cardiac output are the same exact thing. The medical term for minute volume is cardiac output. It's what we use in the hospital. It's going to be 4 to 8 liters per minute. It is something we do measure and do monitor. But we have our cardiac index. Okay, cardiac output is adjusted for body size. All right, so we calculate by dividing cardiac output by body surface area. Now, I'm not expecting you to get body surface area. There are calculations for this in the hospital setting, but we do have people coming in and we do calculate their BMI and their BSA, okay? And then we have our normal cardiac index range from 2.5 to 4 liters per minute centimeter squared, okay? So you guys really got to know this stuff. Make sure you're aware of your ranges. I will never ask you to calculate a cardiac output because I think you just should know that. Okay, but you definitely need to know 4 to 8 for cardiac output, 2.5 to 4 for cardiac index. Okay, heart rate. Autonomic nervous system controls, I've already talked about this briefly. SNS activation, increased heart rate, increased contractility, okay, and increased conductivity. We're going to go faster, harder, and we're going to increase that blood pressure as a result initially. Parasympathetic, we're going to go down in terms of rate, down in terms of force, and down in terms of electrical conductivity. So think chronotropy, inotropy, and dronotropy related with these ideas here. So here's a big wink, wink shooting star. The three, and you may see this on the test. The three main factors that assess or alter stroke volume are preload, afterload, and contractility. Okay. The amount of blood in the ventricle prior to systole. So, in other words, how much did I fill you? Okay. And you should know these numbers as well. You'll see these on the test, most likely. Ejection fraction is 60 to 70%. That's our normal range. And your rough stroke volume, okay, how many mLs per stroke you eject from the left ventricle, should be roughly 60 to 70, sometimes a little more than 70, and that's perfectly fine. With that being the idea is that we have roughly 100 to 110 mLs filling into the left ventricle during diastole. We're ejecting 60 to 70% of that for a total stroke volume of 60 to 70 mLs. So when I say preload, this is how much the left atria or the right atria has pre-filled the ventricle prior to contraction. Okay, very important, because if I don't fill it adequately, there's nothing to eject, even if I do contract. So that preload, that's what we're focused on there. Afterload, similar, but on the back side of the heart, on the way out. Okay, and remember, I like to split the heart into a right and a left. You already know it's a right and a left, but I like to point out in between the right and left side of the heart is the pulmonary vasculature and the pulmonary system. Okay, the pulmonary vasculature and the pulmonary system can act exactly like your peripheral blood vessels in that they have the ability to increase pressure on and stress and demand on the right side of the heart while leaving the left side of the heart completely alone. Okay, and we'll talk about that more, that particular concept a little bit more, but likewise, on the left side of the heart, you can have increased stress on the left side of the heart that stems from increased systemic vascular resistance or peripheral vascular resistance, resulting in a state of hypertension. I have to contract much harder to overcome a hypertensive state than I do my 110, 120 systolic. That's what I would like to see. But 150, 160 means my heart has to work 33% to 40% harder than it should. So, but that's what afterload is. Afterload is how much pressure I need to generate with my left ventricle or right ventricle to overcome the pressure in the next system or outside of the ventricle. For the left ventricle, it's the aortic arch, okay, the aorta and all peripheral vessels. For the right ventricle, it has to overcome the pulmonary pressures so it can maintain adequate pulmonary perfusion. Okay. But what we're looking at is, for example, if it's 130, 140, 150 outside my left ventricle and throughout the aorta and throughout the peripheral systems, and the peripheral systems say, yeah, we're sitting out here at 150. Well, your left ventricle now actually has to generate enough pressure to overcome that. Now, obviously, this is a loose example, just purely through numbers. Okay, if you actually looked at a pressure gradient in the body, pressure is decreased the further away you get from the heart. So your highest peak pressure actually sits in that aorta. Okay, so if I have a pressure in the aorta itself of 150, for example, the heart has to pump at 160, 165 just to overcome an adequate capacity, that afterload. Okay, so afterload is the amount of pressure put back on the squeezing portions of the heart, the working portions or pumping portions of the heart. And then lastly, we have the concept of contractility, and that's how aggressively, how violently, how efficiently the muscle can contract. Okay, the healthier the muscle, the better it can contract, the more completely it can contract. The healthier the muscle, the more it will also expand during filling. Okay, so if you have healthy heart muscle, we want it to expand during diastole and then contract down and eject its contents, or 67% of its contents. So a heart that works out is a heart that does yoga. The more it stretches, the more it can fill. The more it fills, the more it can the more it ejects, in the sense that when I increase my demand and I increase my violence or force of contraction, I actually get more cardiac output with each beat, more stroke volume. Okay, so those three things are what impact your stroke volume. You must know them. We will talk about them more. I accidentally just talked about all of this. Okay, but we'll just quickly skim back over it. Okay, right. This is a concept you definitely need to know. Right ventricular preload is affected by right arterial pressure. Okay, measured as CVP. And the left ventricular preload is reflected by the left ventricular end diastolic pressure, also measured as a wedge. We talked about that earlier. Okay. Starling's law, you've heard it before. I'll just review it again. Increased volume equals increased stretch within physiological limits. Yes, the chambers of the heart have a degree of elasticity to them, and we do want them to expand, and we do want them to contract back down. On contraction, obviously, not before. Afterload and things that affect afterload, lumen diameter, the more narrow the lumen, again, think sclerotic buildup here, or clot even, okay? The more narrow the lumen, the more pressure it's going to put back on the heart, the left ventricle. The more open, within reason, I don't want these vessels too dilated, the easier it is for blood to flow unobstructed, requiring less pressure from my heart. Then we have the thicker your blood, the harder your heart has to work. Okay, the thinner your blood, the less your heart has to work. Then we have our concept of systemic vascular resistance reflected in the left ventricular afterload. And remember, I tied these two concepts together earlier. Systemic vascular resistance equals Systemic hypertension. And we have peripheral vascular resistance. Okay, reflects right ventricular afterload, pulmonary hypertension. Okay, and this is what's going to put pressure on the right ventricle. I did talk about that. How do we measure systemic vascular resistance? We measure it in dynes per second, centimeters negative to the negative fifth power. What you need to know, it's between 8 and 1200. Some books say 9 and 1200. I'm perfectly fine with either one. You must know 8 to 12 for me. Okay, I will test you on this value. Systemic vascular resistance increases with hypertension and aortic valve stenosis. And what that means is the valve's getting rigid, it's getting hard, calcified. It absolutely decreases the amount of output we're going to have, but increases systemic vascular resistance, causing a state of hypertension. Vasodilators decrease systemic vascular resistance. Very simple concept here. You have hypertension. I give you metoprolol. I give you a calcium channel blocker, nifedipine. I give you an ACE inhibitor, an ARB. I give you these things. They dilate the blood vessels. They decrease the amount of pressure on the heart, and therefore, when we take stress off the heart, we're not working as hard. Okay, and that's why hypertension is such a big deal. Then we have vasopressors, which do the polar opposite. We increase systemic vascular resistance. We're clamping down on the blood vessels. And it's not because I want to make the heart's life harder. I'm not trying to make the heart by itself contract harder. Don't get me wrong. I am asking for more, but I'm typically also trying to shift volume amounts back to the heart. Many forms of shock create a state where the heart isn't getting adequate preload, adequate blood flow back to the heart, so it doesn't have enough to even pump out. By clamping down on our blood vessels, not only do we increase systemic vascular resistance, not only do we ask the heart to please contract harder to overcome this resistance, but we also get more blood back to the heart. And remember, the heart feeds itself. If the heart isn't pumping adequate blood out into the aortic arch and back into the coronary arteries, it's not perfusing itself. So by clamping down and supplying more blood back to the heart, we are essentially helping the heart supply itself with oxygen, nutrients, and get rid of the waste. Pulmonary vascular resistance, you must know 100 to 250. Okay, I will ask you that. But think systemic vascular resistance, think PVR, same exact thing, but for the right side of the heart. Same exact thing. So what can happen to the pulmonary system? Oh, well, the same thing, sclerotic buildup. We can have pulmonary embolisms as a foreign body obstruction. We can have vasoconstriction, spasms, okay? We can have states of hypoxia and persistent pulmonary hypertension. Everything that can pretty much happen in systemic vascular resistance, all the same exact things can happen in the pulmonary system. They just, sometimes we have some different names. Things that affect contractility, you should probably know this. Static of the cardiac muscle, is it healthy? Because it will stretch much further, it will contract much harder. If it's not, and it's stiff and it's rigid, and we have cardiomegaly, we have a stenotic, left ventricle, whatever the case may be, it's not going to expand as well, therefore not filling as well, and therefore your stroke volume will decrease. Well, if the stroke volume decreases, that's a problem. Okay. Also, if I can't contract down as hard because my muscles are swollen, I can't eject as much, and my ejection fraction decreases, and once again, stroke volume decreases. Rate rhythm, absolutely. Okay, intravascular volume, absolutely. So what's in the vessels, what's in the blood vessels, what's returning to the heart, and what's in the ventricles themselves. Electrolytes, basics here, sodium, potassium, chloride, we got our magnesium, our calcium. We're definitely monitoring those. If you screw those up, your heart and pretty much any muscle in your body will not work the right way. Oxygen, ventilation, ischemia can change that state of contractility because, again, these are muscles. We're asking them to do a job. Don't give them the proper nutrients, proper fuel. No, they're not going to do it. It's no different than going to the gym and doing a specific exercise, thousands of times. Eventually, the muscle will fail. Your heart's no different. And then we have our drugs that increase contractility. Most common ones are epinephrine, dobutamine, dopamine. They all have dromo and inotropic, chronotropic properties to them. But specifically, when I say inotropic, we're talking about the force of contractility. All right, talked about this. You should already know this. Normal ejection fraction, quick quiz, 190, 80, 70. 70. Okay, you definitely need to know that. We assess this via the cath lab. We can do it via angiogram, or we can do it via echocardiogram or an ECG. Okay. All right, so we're going to talk about arterial lines, CDPs, PA catheters, and LA lines. Okay, here's the terms. Let's move on. Hey, look, it's beautiful. There's a lot of numbers here, and at first glance, I admit, it can be a little daunting, okay? But it's actually not too bad. heart rate, currently sinus tach, 108. We have our SpO2, 96%. I like that. We have our arterial line. Okay, and look at that waveform. We're going to talk about the waveform, by the way. We're actually going to go take a peek at it a little more in depth. We're going to look at the waveform and what parts of the waveform are relevant to us and what they mean, more importantly. Because believe it or not, just like a EKG or an ECG, we have different portions of the wave that mean different things, such as the systolic phase versus diastolic phase. And we will talk about the dichrotic notch and all that, so don't worry. But that's a second by second update. Active pressure, 180 over 91, slightly hypertensive. Wonder what's going on. Down here we have an ICP monitor, okay, and it's an intracranial pressure monitor. Intracranial pressure on this patient is a little elevated, not too bad, but definitely an issue. We don't have anything we're discussing just yet on intracranial monitoring. I will discuss this later in the semester when we get into kind of the brain, the head, and neurobiology. Okay, down there we have 27. We have our respiratory rate. All right, we have the mean. We have all sorts of cool stuff over here. We have temperatures, I believe. Yeah, we have temperature. There's a lot of numbers here. And I know I can show you this picture. When you guys actually step into the ICU, that's when you take the time, even the ER, some of the more critical patients in the ER will have some of this going on, but a lot of your ICUs do. But you're going to go hook this up. You're going to look at it. Okay. Now, I want you guys to identify the numbers, their values, and what they mean. Get used to looking at this. It looks confusing at first, a lot going on, lots of numbers. If you don't know, ask the nurse. Yes, there's usually a lot going on, minus the smile. Just kidding. Look, ICU's fun. Hemodynamic monitoring equipment. Okay, you definitely need to know your three kinds of catheters we're discussing. So we have our arterial lines, CDPs, and Swan-Ganz. You need to know how to flush the system. The base flush solution will always be normal saline. Okay, and when I say flush, that's how we clear the line out. Unless indicated by a physician that he would like something like heparin. Okay, maybe you have a patient that has hypercoagulability. Well, in that particular instance, you may have a pulmonologist or intensivist, whatever the case, we'll put it in, that may order heparin rather than normal saline to be used in that tubing. Obviously, we're going to be very conservative with our flushes. We are not bolus dosing, our patient with heparin at will. We are simply trying to keep the line patent, open. That's the purpose of a flush. We have our transducer. Okay, our transducer is honestly the key to the whole entire thing. It's what converts our electrical information coming from the body, our pressure information, into numbers. Must be accurate, must be placed correctly, and I will show you that. We have our amplifier, and that's what actually picks up the electrical signal, transmits it into the cable, down the cable, and again, the transducer goes, ooh, pressure. Okay, and that electrical charge actually stimulates a pressure, and then we give it a value and a number, and it shows up on our monitor. Woohoo! This is that transducer. This is our three-way stopcock. Okay, here's our electrical hookup to the monitor. And typically there would be tubing attached to both ends. Looking at this one's going to the patient, the blue one. The white one would be going up to the bag of NS or heparin. And then this one has how we open these three-way stopcock to atmospheric pressure. We're not removing the red cap. We're going to keep that in place. And this right here needs to be placed at a very specific location in relation to the patient to present accurate values. So let's talk about leveling, zeroing, and calibrating. Where are we going to level it? We call it the phlebostatic axis, wink, wink, shooting star. Fourth intercostal space, mid-axillary line, left or right, doesn't matter. I'm going to tell you this right now. If you have it too low, your pressure will be too high. If you have it too high, your pressure will be too low. If your patient moves, and this is something that happens all the time, especially with newer nurses in the ICU, and I touch on this because it's one of those things that's easy to fix. Okay, sometimes we freak out and, oh my gosh, my pressures have been great all day. And by great, I mean you have them on 3-4 pressors. They've been 100 systolic on the button, and all of a sudden they're 80 systolic. And you're like, oh my God, I'm supposed to titrate to 90 systolic or a MAP of 65. Oh no, I need to titrate, but I'm running out of room. Oh no, I'm having to trend up. Well, before you jump to all those conclusions, maybe look where your transducer, and by the way, this is the transducer. Make sure your transducer is sitting at the phlebostatic axis. More often than not, and depending on where you work, depending on what kind of beds you have, I like to attach my transducer to the patient themselves so they can tolerate it, or to the bed. Okay, because when you're moving the patient up and down to clean them, to move them, to roll them, to do your 2 hour, turns, to do oral care, to do VAP care, whatever the case may be, and you move and manipulate that bed. If you have it attached to your IV pole, that's fine, but that means you also have to re-level it every single time you move the patient. Whereas if you have it attached to the bed of the bed goes up, it goes up with the patient. Okay, so keep that in mind. And I can't tell you, and I mean like 80% of the time when I have some kind of acute change in pressure, we fall back to a change in the position of the arterial line, the transducer. There's typically a very clear reason, and I can troubleshoot that, fix it, and boom, pressures are back up to that 100 mark that we've been at all day. Okay, so just be aware of that. To zero balance the transducer, it's pretty easy. We're actually going to close it to the patient, and we're going to actually open it, excuse me, other way around. We're going to close it to the bag and actually open it to atmospheric pressure. Okay, and that's the first one. And then we're going to close it to the patient, flush the line, open to atmospheric pressure, and then flush the line out completely. Okay, and your machines will actually tell you when your zeroing is done. If you do it incorrectly, most machines actually tell you zeroing incomplete or cannot be completed. And again, best way to do this is to ask a nurse. Ask a nurse to demonstrate and to show you. Okay. Anytime you move the patient, if it was not moved in synchrony with the patient, it's going to have to be re-leveled and re-zeroed. Phlebostatic access. 1, 2, 3, 4. Bam. Mid-axillary. Bam. Phlebostatic access. Dude needs a wax. All right, intra-arterial blood pressure monitoring. We are actually measuring inside an artery. Our most common access sites, radial, femoral, brachial. You must know that. You must know and be able to list these. You got to know what it's for. You got to know where it is. Okay, where our insertion sites are. Radial is the most common one. We use the Allen's test to determine if I have adequate or patent radial blood flow. Femoral, we don't check. It's a larger vessel. You do not need to check blood unless there is obvious signs of malformation or something else going on down the femoral region. I'm not going to check for peripheral blood flow there or brachial blood flow. Okay. Sometimes, and it's not super common, you will see what's called an axillary arterial line. And an axillary arterial line is no different than any other arterial line, but it's kind of in a funky place. It can sometimes be really challenging to keep it in place, especially if you have a patient that's moving, is ambulatory. So just be aware it does exist. Those are your most 3 common sites: radial, femoral, brachial. If you see it on a test, I would definitely take axillary as well. Okay. Who's going to get it? Anybody on a vasopressor drip. Okay. Anybody on a vasodilative drip, any vasoactive drips, period. Okay. Any considerations for tissue perfusion, fluid volume alterations, especially big shifts or volumes or boluses. Patients with acute respiratory failure require frequent ABGs, big one there. And patients on vasoactive drugs, I already said that. This is the Allen's test. I may ask you, I'm going to ask you questions about the Allen's test. I'm going to ask you what it's for and why we do it. All we're doing is placing pressure on, and one at a time, not both sides at the same time, one side at a time, placing pressure on the right radial artery or the left radial artery here. Okay, if you ever forget which one's your radial? Oh, thumb. You take your thumb. If you do a thumbs up, that's rad. And rad is radial, so that's radial. Put pressure on the radial artery. You should actually see a change in the color of the hand because you're decreasing blood flow pretty substantially to the thumb, the index finger, and even sometimes your middle finger. Okay, usually your middle finger. You're going to let go. They should refill instantly. You're going to do the same thing on the other side, and what we're doing is we're assessing for radial patency to see if we have adequate blood flow to insert a arterial catheter and monitor with an art line from this location. There are instances where you have sclerotic buildup, calcified arteries, and you cannot get accurate readings at the radial site. In that case, you'd have to go in the femoral site and use that, okay, or a different location in general, maybe even the other arm. So just be aware of that. Arterial line insertion. So just a little bit what's going on here. We have our cuff, okay. We have our, and that's an IV. It's not part of the line, okay. We have our pulse ox down here. We got a lot going on in this extremity, and my assumptions here are this patient's probably more in a critical state. So right now what's happening is the physician or the practitioner or provider is getting ready to insert this catheter. They're currently palpating for the radial pulses. They're going to find them, okay? All right, found them. Boop. And typically they're going to find them with not just pulsatile sensation. A lot of people use ultrasound now. In fact, ultrasound is the gold standard in how the treatment is taught. Excuse me, intervention is taught. So once they locate the artery and they found it, they mark it, they go ahead, they feel for it, and boom, we insert the bevel, the tip of the catheter. We find it, we get flash, and then it's just like an IV, but for an artery. Okay. I'd like to point out, as a nurse, you got some things you definitely need to be aware of here. I mean, you're not the one putting it in, but you're going to be the one who may identify the need or indication for an art line. You're going to be the one that maintains the art line, and you're going to be the one that's going to have to troubleshoot the art line after it gets placed, probably. So, what are we going to do? We're going to compare intra-arterial pressures with cuff pressures. They should be within about a systolic value of plus or minus 10 of each other. Okay. Check connections in the system. Absolutely. I can't tell you how many times it's become an issue in the ICU again, especially with less experienced nurses coming through. Sometimes mistakes are made. And what I mean by that is you open the stopcock or the valve and you leave it open. Now, obviously, your line on the monitor will go completely flat because it's not going to measure anything because it's closed to the patient or open to the atmosphere or closed, whatever the case may be. You need to troubleshoot that. Okay. I'm going to remind you that if you accidentally leave this open, okay, so say you close it off to the NS or the heparin bag, leave it open from atmosphere to patient. The patient has more pressure in their arteries than the atmosphere does, and they will shove blood into that tubing and they will pour blood out of the artery and into the outside atmosphere or out that tubing if left open. I have walked in after a blood gas had been gathered. The individual that was there prior gathering the blood gas had left the stopcock in that position. My monitor was even like alarming, hey, zero, zeros. Actually, it was negative 300, but negative 300, which is not an actual pressure, not a thing. Walked in the room, had a pretty good pool of blood on the left side of my patient there, and I couldn't even see it because they had put the blanket back over the arm. So, and in this case, my transducer, where my stopcock was taped to my patient's left arm, okay, up by the gown. So, uh, you may have to troubleshoot. Look at your lines, look at your connections. Are they all together? Are they sealed? Yes, good. Okay, look at your insertion site. Is your tubing kinked? Is your tubing coming back? Is it coming out? Does your dressing look dirty? Does it need to be cleaned? Has it been 7 days? Because we change these dressings every 7 days. I check my site, I check my circulation, I check for phlebitis, inflammation, swelling, redness, any discharge from insertion sites that could indicate infection. I'm looking at all this stuff. I'm making sure my bag doesn't run out of NS or heparin. I'm making sure my alarms aren't coinciding with what I'm monitoring. For example, most of your vasoconstrictors typically are titrated off values such as a systolic above 90, equal to or above 90, or a MAP equal to or greater than 65. So when I have these values and I want to monitor them, I need to make sure I can go into the monitor, change my parameters to reflect exactly what I'm attempting to monitor. Okay. Here's the full setup, and you will see this in the ICU. This isn't a maybe, absolute. I guarantee you right now. And you go into Desert Valley, St. Mary's, San Antonio. There's patients currently sitting there in their ICUs with this exact setup. Please go look at it. Familiarize yourself. Do not touch it, okay, unless you are with a nurse and the nurse is observing you, talking to you about it, and teaching you. But here we go. Pressure bag, NS or heparin. Whoop. Typical IV tubing. Even have our little stop here. Cool. Three-way stopcock to the bag, to the patient, to the monitor. Okay, transducer. Remember, phlebostatic access, please. And there's different locations for the flush device. Some transducers have it in the dead center of them, like ours at St. Mary's, are in the dead center of the transducer. You just pull a little knob and it flushes the whole thing. Other ones are a little different. They're screw on, screw off, or turn or twist, or whatever the case. Put pressure on them. We have our pressure tubing. Okay. You're going to have typically a hub somewhere in the tubing between the transducer and patient, and that's where we collect samples. We don't give meds. Really quick. Put a wink wink shooting star next to this bad boy. We do not administer any medications via my arterial line, period, at all. Okay. You're like, well, Instructor Bear, what about heparin? We're not administering heparin. Okay. I'm using heparin purely to keep that line patent, to keep it open, to keep it usable, functional. That's it. I am never going to be like, you know what? I think I'm going to eyeball about, let's let them feeling wild today. 2,000 units of heparin sounds good. We're never going to do that. If I want to give patient heparin, if I need a thinner, if I need to do something like that, I'll go ahead and I'll actually go get a vial, a 5,000, 2,000, 5,000, 10,000 vial, administer whatever's ordered by the physician. That's a completely different instance. We have no metric here, no way to measure it accurately. I'm not doing that here. Okay, and I'm not infusing any medication through the arterial line at any time, ever. Not usable. Only collecting specimen, collecting blood, collecting arterial blood gases, absolutely, but nothing else. Okay, let's move on. The dicrotic notch. This is exactly the waveform you're going to see based off of that arterial line that you have. You're going to see the systolic phase, and you must know this. I want you to know when the systolic phase starts, when it ends, and when diastolic phase starts and ends, because you'll see that literally at the increase, as we see that we're coming in the down slope of our waveform, you'll see a slight up spike or uptick, and then we call this the dicrotic notch, that little upswing. This is where the diastolic phase is actually beginning. That's why you see peak pressure, peak work. Oh, I'm gonna relax, refill, and do it again. Whoop, excuse me, come back. Okay, so up, peak pressure, coming down, relaxing, relax. Oh, refill. Okay, relax, refilling, and spike again. Okay, this is how it should look. It will not always look this way. If you're one, so let's say I have a similar one. Okay, but like let's say it's like this, just like an arch. That typically means there's something going on with the arterial line. Either my pressure bag's not inflated, or maybe this waveform like looked like this all day, and then all of a sudden this waveform's down here. This little tiny wave, no dicrotic notch, maybe a baby dicrotic notch. Oh man, my pressures are dropping. Go look to see if your pressure bag's inflated right away. If your pressure bag's not inflated, it will actually dampen, okay, the reverse pressures, and therefore it starts decreasing your waveform values. So if you see these, again, like kind of like just like a tombstone or like a half dome looking thing, chances are either your bag's deflating, your arterial line may actually be pressed up against the arterial wall, or it may have a clot on the end of it that is beginning to form, obstructing blood flow and sensing from the arterial line. So that's where we start flushing stuff. Okay, so we flush it out, we zero, connection's good, pressure bag value good, all right, everything's good, and it's still the same. You may have to go grab another more experienced nurse to troubleshoot it, or you may not be able to fix it. Okay, but that's why maintaining the line is so important. Let's talk about my favorite, Swan's Ganz catheters. Dr. Swan and Ganz, two different doctors. Balloon-tipped multi-lumen catheter typically has, I believe, 7 ports, if I remember right. Purpose use, it's for direct measurement of left heart pressures. Okay, just like we can monitor an arterial pressure, radial, femoral, brachial, or axillary, we can monitor other vessels that are specifically linked to, let's say, the left side of the heart or the right side of the heart. Okay, so for example, I want to measure how much pressure the right side of the heart is pumping against. Well, how would I do that? Well, it's a good question. I would use a Swan-Ganz catheter. Okay, what can I measure? All sorts of numbers. Okay, PA systolic, diastolic, mean, wedge, PCWP, pulmonary capillary wedge pressure, arterial pressure, occlusion pressure. What are we assessing for? We're assessing for how hard the heart is having to work. Okay, we're assessing for pulmonary hypertension. We're assessing for volume status preload and afterload. Cardiac output, you can measure with the Swan-Ganz. And this one is a big one. You can obtain mixed venous blood gases. I'll explain that in a moment. And then measure how much O2 we are consuming with SvO2. This right here is what a pulmonary artery catheter looks like. We have a lot going on, actually. Okay, that little baby balloon down here. And yeah, I would point out, I believe the balloon size, if I remember correctly, is about 1.4 to 1.5 centimeters in length, and diameter is about 1.7 centimeters inflated. If I also remember correctly, I believe it takes 1.5 mLs or 2 mLs. I'll have to verify that. But we have different ports, okay? We have our RA infusion port, and these go to, and I'd point out, very specific locations, okay, and are used for very, very specific things, okay? So when we talk about this, I definitely want you to be aware of what this is, what it looks like, and its various uses, as well as the fact that this balloon is inflated on the tip. And when we inflate that balloon, we can actually take measurements. Okay. What measurements specifically? Well, pulmonary wedge pressures. So let's talk about insertion, excuse me, of the Swan-Ganz catheter. Typically going to be getting one in the IJ right here. Okay, internal jugular. No, radial will not work. Brachial will not work. Axillary will not work. This one is a very specific one that has to go in the IJ. Okay, because if you look at where the tip of the catheter is terminating, look at how we're moving here. Okay, so we go in to the internal. I guess we could go in subclavian. I apologize. I don't see subclavians very often. I do see IJs. But anyway, so we're going back in the superior vena cava through the right side of the heart, right atria, right ventricle, and we're actually going up into the pulmonary artery, okay, and that's where we're going to remain. So basically we are in the blood vessel that is going from the right ventricle and going to the lungs. We have not yet reached the capillary bed in the lungs. Okay, so this is before the capillary beds, and this is where we can measure pressures. I will show you that in just a moment. So you have different ports, different uses. Okay, we have our proximal or RA port, usually blue, monitors right arterial pressure. Okay, and then we have our cardiac output injectate port as well. Second proximal port is our VIP port, usually clear or white. In my opinion, or my experience, it's usually white. This can be used for IV infusions, but it's only the second proximal port. Okay. The distal port is going to be used for monitoring your partial arterial pressure only, PAP. It's typically yellow. Okay. So after the distal port, we have our our balloon inflation port. Okay. This one, and I put a big star next to this, not purely for testing, but more as a red flag. Okay. This is a very important port, a very critical thing to monitor and pay very close attention to. Reason being is this port has the ability to really harm the patient if used improperly or something goes wrong with it. Okay. So our balloon inflation port is usually red. Okay. And this is where our, and you saw it earlier. Scroll back. Oh dear, come back. There it is. And notice how it's this little short red line, and notice how it even has its own stopcock built in. Okay. Well, what this is, and by the way, these syringes typically come with the kit. Okay, and they typically are limited to the exact amount of mLs allowed in that balloon. We do not just grab a 10 ml syringe, pull back some air, and slam it in there. You will rupture that balloon, and if you rupture that balloon inside the patient, congratulations, you have just inserted a massive air embolus directly to the pulmonary vasculature. Congratulations. You might kill your patient. Don't do that. Okay, so this needs to stay hooked up at all times. If it's not in use, the stopcock needs to stay closed. Okay, and you need to constantly monitor for any kind of issue with that line. All right, I will point this out. When you inflate that balloon, think about this. You are essentially causing a complete occlusion of whatever vessel that is in this case, the pulmonary artery. Okay, when you block off the pulmonary artery, and again, we're measuring pulmonary wedge pressure here. But when you block that artery off, you essentially block off all blood flow. It's as if there was a fully 100% occluding pulmonary embolus sitting there in the artery, blocking the whole thing off. That's a big deal. No blood is flowing from the right side of the heart to the artery and into the lung. You are stopping that flow. And we do that, okay, at very specific times or intervals as indicated by your physician or your provider to measure that wedge pressure. And that's the only time we're going to do it. The minute we're done measuring that pressure, that balloon gets deflated instantly. Okay, because otherwise that balloon sits there. Not only does it block off flow, but it actually stops stops platelets, can form clots, and the blood just sits there static. We don't want that. When I say inflate, this balloon is inflated for a matter of seconds. You don't just leave this balloon and, okay, take a 15-minute read, your patient will be dead in 15 minutes. There is no 15. This is a matter of seconds. Okay, we get our reading and immediately deflate. It's very simple. Then we have our thermistor report, thermodilution, and cardiac output measurements. I'll show that to you as well. There are some different slash updated versions of this, but generally they keep their same colors. Okay, and you can see we have essentially 4 ports on this one, and we have 3 different measurement metrics on over here and hookups. But again, we have our red, yellow, white, and blue. If you ever have a hard time remembering, you can always come back, and the one I always remember is the white one, because the white one is the only one I should be putting things inside of in terms of like infusion or medication. There are other versions of Swan-Ganz catheters that do have other ports on them as well, but for the most part, this is what you're going to see or get when you talk about a Swan-Ganz. Okay, I already showed you this. Here's our little baby balloon. It's actually smaller than I stand corrected. I believe I said 1.5 centimeters earlier. I stand corrected. I believe it's 1, and my metrics were off, and my mLs are 1.5. I do apologize for that. So that balloon, and it's not even a full 1 centimeter, so much as the tip of inflation is 1 centimeter. But look at that balloon. It's just a little baby balloon. The minute you inflate that, you are blocking off that artery, and you are getting a reading. Okay, so you insert your 1.5 mLs of air. Boom. You're going to see a initiation in waveform and pressure, and I'll show you that too. The minute you're done and you have that captured, you deflate it instantly. Here's how this would look. And here's your different waveforms, by the way. These are the different portions that we're looking at. So when you say, I'm going to insert a Swan-Ganz catheter, we're actually going to say, you might hear the physician say, I'm going to float the Swan-Ganz catheter. Because if you actually look at this, check this out, it's pretty interesting, I'm not going to lie. We're going in through the superior vena cava, right atria, through the tricuspid valve, and you notice how we got to take kind of like a 45-degree turn to the left here, all right, or the turn inferior, whatever, or excuse me, superior, whatever the case may be. But you got to make a pretty sharp turn. And no, do like, well, why don't you just line it down the inside of the right ventricle and let it slide around the ventricle and back up? Because you would stimulate the entire cardiac muscle and potentially throw your patient into a dysrhythmia. We don't want that. That's bad. Not good for health. Not good for life. So as you're moving, okay, and as we're inserting the catheter, this is what we would see on the monitor. Okay, we're going in, and you can see the balloon inflated there on the end. We're going through the RA, okay, right atria. This is the waveform you'd see, very low, very depressed, not a lot of pressure. The minute you pop through that tricuspid valve, we're going to see a substantial increase compared to the right atria in pressure. We're going to see boom, 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 boom. There we go. We've got some good pressure going on. And then once we are out of the right ventricle and into the pulmonary artery, you're going to see we're maintaining the pressure, which makes sense, but the waveform will decrease because our pressure ranges are different. Okay, you see right atria over here. We've got all the way up from like 25 to 28, potentially even 30, all the way down to roughly about 2 to 5. Okay, over here on the pulmonary artery, we're still up there. We're hanging out around 25 to 30. All right, but we'll notice our lower number here is going to be closer to 15 to 18. And then PCW, pulmonary capillary wedge. We are there. We are where we need to be in this final image. Okay, we move through, boom, pulmonary artery. I'm where I need to be now. Okay, I'm there, I'm present, and this is the waveform we're going to see. It almost looks identical to that right atria. But we're in place now, and you're going to see a much smaller waveform, and we're looking to measure these peak waves. This balloon does not stay inflated. Once this has been floated and is suspected to be in place, we will deflate the balloon, and we will do the only thing that can show us exactly where it is, imaging. Okay, we can do a chest x-ray to locate this, or we can do more often than not. So when we further discuss these accesses that allow us to monitor these hemodynamic properties, aside from the Swan-Ganz and the ability we have to go in and measure cardiac output, those wedge pressures, we also have, in conjunction with ART lines and the Swan-Ganz, we have the CVP line. Okay, and I like to call this one the red-headed stepchild, if you will, purely because we like to forget about it. It's not that it's not important, it's not that it's not valuable, it's just that the other two often present numbers that are incredibly critical. So, and again, CVP is important. You must know your CVP ranges, 2 to 10, okay? And the idea here is we are measuring volumes, okay, from a central line. The lines can be inserted internal jugular, subclavian, femoral, and again, we're in the veins here. We're not these aren't arteries. So I'm going to point that out. And the tip of that catheter is going to terminate typically at the right atria. And so this is a central line, and we are going to monitor the amount of pressure, okay, in that venous cavity. And then from that venous pressure, we're going to assume preload and fluid volume availability. So again, 2 to 20, or excuse me, 2 to 10, my apologies. If you have 20, it's a bad thing. We have different waveforms. We have the A wave, represents atrial contraction. We have the C wave, closure of the tricuspid valve. Okay, and then V wave, final atrial filling as the valves are closed. You should know those. I won't test you on them, but again, it's good to see and good to know. The idea here is if your numbers are too low, and by the way, you can never have a negative reading. I had a nurse one day come up to me and she's like, "Yeah, we have a reading of -7. I think he's in a fluid volume deficit." I'm like, well, it's not a thing. You can't go below 0 because that would mean you have no fluid. There's nothing below 0. There's -1 doesn't mean you owe me a liter of fluid. It means you don't have anything inside of you at all. 0 is the lowest you can go. So, but the idea is the lower we go, the less fluid volume we have available to preload the ventricle with. Okay, go for the opposite, can be said. So if I'm up at 15, 18, I'm fluid overloaded and I have too much fluid volume and I need to take fluid volume off. Now, these are not standalone measurements by themselves, are not direct indicators for example, let's say I have a reading of 18. Okay, saying I have fluid volume overload severe. Well, my blood pressure is 90/60. I don't have any pulmonary edema. I don't have crackles. Okay, we're not just going to automatically dump 40 to 80 of Lasix into you and hope that you urinate out your excess volume. We are going to keep a close eye. And just like the arterial line, the CVP is the same exact line set. Pressure bag, everything. Transducer, all of it's the same. The only different part of the CVP is where we are measuring, essentially, what we are measuring and where that catheter terminates. Whereas an arterial line is in an artery, okay, we are measuring the actual pressure in an artery second by second. We are measuring, in this instance, the volume in a central line, typically the right atria, and we are monitoring that value. Okay, there are critical indicators with this, and there are critical indications of what can happen to a patient if they stay in a persistent state of decreased CVP, and especially in the ICU when you have patients that are critical. You know, we measure maybe an arterial pressure. We're trying to keep that MAP above 65. Don't forget MAP, mean arterial pressure. Okay, you have to have a certain amount of pressure at all times to perfuse the brain, the heart. Not so much the heart. The heart can perfuse dead last. The lungs, but especially the liver, and more importantly, the kidneys. Okay, then you have to maintain a certain pressure to get blood down there and actually get blood into them so that they can stay alive and keep flowing. So a lot of the times when we look at these CVPs and we're looking to see if patients have enough fluid volume, we're looking to see if there's enough preload, enough vascular support to get pressure, adequate pressure down to the renal arteries. And if there is not, this is a direct indicator of poor renal outcome and worsening condition. Remember, what's attached to the top of your kidneys? You've got a little set of glands there, okay? And those glands are directly responsible for the secretion of various hormones, most of which activate the SNS or regulate the renin-angiotensin-aldosterone system. So, not just that, they're responsible for waste deletion in the form of urine, uric acid mitigation, regulation of sodium, potassium, chloride, magnesium, etc. So when your kidneys go out, it's a big deal. But anyway, CVPs can help us monitor fluid volume and ability of the heart to have preload available to it. In instances where preload is low, my pressures are low, my CVP is low, you're probably going to see the doctor go ahead and say, go ahead and give a bolus or give them a fluid challenge. Okay, and that's where we get that 250 ml bolus or maybe a 500 ml bolus. We see how they tolerate. If their CVP improves and their blood pressures improve, their heart rate decreases, then okay, they needed some fluid, and then we're going to mitigate, or we're going to see how the patient tolerates that challenge, and then we're going to transfuse more fluid based on that. Okay. So here's the actual representation image. There's our atrial contraction. C, here we go. There's the closure, tricuspid valve. And then lastly, we have the atria that are filling as the valves are closed. Okay, I will not ask you to memorize this, just be aware of it. Must know your CVP. Okay, CVP is elevated, they are overhydrated. CVP is decreased. Think hypovolemic shock, not enough fluid, or fluid volume shift into the third space, meaning it's in their tissues where it doesn't belong. Typically, I'd be looking at my albumin levels now or any kind of sepsis pathology. All right, let's look at pulmonary artery pressure. Okay, normal values, and these are ranges. Just like you have a 120/80, we now have a 20/8 to 30/12. These are normal ranges for your pulmonary artery pressure. Okay, the systolic pulmonary artery pressure is the same as the right ventricular systolic pressure. Pay attention to that. Pay attention to that. Diastolic pulmonary artery pressure is the same as the left atrial pressure. These values are important to know, and this is where that Swan-Ganz comes into play and what we're monitoring here. Okay, I know we stepped away from the CDP, but when we're talking about the Swan-Ganz, and you got to know this. PAP, think 20 to 30, 8 to 12, systolic, diastolic. Just like the left side of your heart has the diastole and systole values in the chambers, the right side does as well. And we can measure the right-sided right ventricular systolic pressure with the systolic pulmonary artery pressure. Wink, wink, shooting star that. And here's what we're looking at here. Here's your pressures. Look how little pressure's in your right atria. Okay, and even then, 38/5, that's a big jump. Not really. Not comparatively to your left ventricle. And then over here in our right ventricle, and how would I measure this? I would measure this with my pulmonary artery pressure. Okay, so I got Swan-Ganz sitting right about here. Okay, all right, I see it. All right, I measure it, 38/5. Okay, this 38/5 exists so it can overcome the pressure in the pulmonary circulation. By overcoming the pressure in the pulmonary circulation, we get blood flow to the lungs, we exchange our O2, CO2, and we go back to the heart. Left atrial pressure, 26, can be measured by the pulmonary artery pressure, and that's indicative of what we're going to see going into the left ventricle and left atria, and how hard it has to work or what values or pressures are there. Last stop, that left ventricle. And this is where we get our blood pressure from. Remember, systemic vascular resistance, peripheral vascular resistance dictate how much pressure the left ventricle must generate to overcome the pressure in the body and get blood flow out in an adequate fashion. You must know these ranges. Straight up. Pulmonary artery systolic and diastolic, you must know 20 to 30 or 8 to 10 or 12. Okay, I don't care. It's back here on the slide if you need to refresh. Same things. Pulmonary artery systolic, pulmonary artery diastolic, pulmonary artery mean, just know 10 to 15. Pulmonary artery occlusion pressure, 6 to 12 is normal. And that's that wedge. This is the wedge. And then we have our CVP, and that's 2 to 10. Okay. Increased pulmonary artery pressure. We definitely need to understand this. Left heart failure, fluid volume overload, pulmonary hypertension is a big one. Pulmonary embolus, we've talked about that briefly, and that one's going to be more of an acute onset versus the chronic onset we would see with pulmonary hypertension, fluid volume overload, or left-sided heart failure. COPD and hypoxia. Decreased PAP, think hypovolemia, absolutely, or right-sided heart failure, absolutely, okay? You must associate this, and this is what I want you to connect. Increased pulmonary artery pressure, think left-sided heart failure. Decreased PAP, think right-sided heart failure, okay? We're going to move past that. This, I do need you to understand the concept, or conceptually, I need you to grasp this. So our pulmonary wedge pressure, okay, pulmonary capillary wedge pressure, pulmonary artery occlusion pressure, same thing, is a direct reflection of the left ventricular filling pressure. So in other words, how much pressure is in the left atria currently filling the left ventricle, okay? Or the ability of, not the actual left atrial pressure, I apologize, that sounds like a misrepresentation, but the ability to actually fill that left atria full, and for that atria to then subsequently fill the ventricle, okay? So our PCW, or PCWP, if I have less than 6, we're thinking hypovolemia, septic shock, acute pulmonary embolus. Again, look at your acute onset versus my chronic onset. If it's sudden, boom, happened real quick, think PE, okay? PCW greater than 18, actually greater than even 15. Non-compliant left ventricular failure, they're not taking their meds, they're not taking their diuretics, they're not taking their calcium channel blockers. I have further failure. I'm stepping into the realm of cardiogenic shock, okay, especially with substantially decreased ejection fractions or volumes. And then potentially, if it was more acute onset and there's some trauma, associated with the onset of this increased wedge pressure, or if there was potentially infection or sepsis indicated with the onset. And this is rare. You don't usually see an increase here because of sepsis. But you would see cardiac tamponade potentially occurring in an instance where the myocardium itself or the pericardium is infected, causing a state of medical-induced cardiac tamponade versus trauma-induced cardiac tamponade. So you'd see that increase in pressure on the heart and therefore a backfeed in pressure in the wedge, resulting in a left-sided or indicating a left-sided heart failure. And all the way up here as high as 25, and I've seen it as low as 22 even. In 22, I've seen pulmonary edema. And what I mean by pulmonary edema is that blood flow. Let's go back to this image real quick. That blood flow, and again, there is lungs in here, and all this little cute netting, there would be lungs here. We're talking about the capillaries around the alveoli. So when that pulmonary wedge pressure is increased, we have a backflow of pressure. Okay, a gradient of pressure. The pressure is higher where it shouldn't be higher, and that's causing backflow. So it's like taking the 15 freeway. It's currently running 70 miles an hour. Fantastic. And this is the assumption everything's good from side to side, from the right side of the heart to the left side of the heart. Everything's peachy. Well, then let's say I cut out half of these. Okay, I go from 4 lanes on the 15 freeway to 2 lanes. What's going to happen to the traffic? Not only is it going to try to slow down, and it will, you're going to have a backup, all that excess traffic that would have been in 4 lanes now goes down to 2 lanes, and it starts backing up into the right side of the heart. From the right side of the heart, we back up to the right ventricle to the right atria, and hey, look, out to the superior and inferior vena cava. Oh my goodness, I have peripheral edema, fatigue, oh no. Well, the same can be said about the left side of the heart. What if my traffic jam is generated from the left side of my heart? And we talk about this way more in coming weeks. But what if the traffic jam is generated on the left side of my heart in the ventricle because of stenosis, megaly, etc., or a stenotic valve, or maybe I have an obstruction of some kind, an infection, cardiac tamponade, etc. Okay, and then we're backing up again, same concept, from 4 lanes to 2. We back up all the way into the pulmonary system. Well, if we back into the pulmonary system, backflow that fluid, backflow that blood flow, what ends up happening at this capillary membrane level is we actually start pushing fluid, serous fluids typically, out of the vasculature and into the alveolus. We don't want that. When you do that, you are drowning. You're essentially drowning your patient. And you have pulmonary edema. The signs and symptoms of pulmonary edema are pretty simple to observe. Okay, typically some degree of respiratory distress. You're going to hear some crackles in the basilar lobes. If you lay your patients flat, their difficulty breathing will get much worse if it is a severe or moderate case. In mild instances, they may be able to tolerate laying flat a little bit, but it gets way worse when you lay them down. People that are at home with pulmonary edema, ask them, hey, have you had a hard time sleeping at night? Yeah, I wake up short of breath. Well, that's because when they lay down, that fluid volume that's typically only in the bottom of the lungs has now expanded over the entire surface of the posterior aspect of the lung, or anterior aspect, either way, depending on what position they sleep in. So now we're covering a much greater surface area, decreasing the ability of O2 and CO2 to exchange. Okay, and we call that paroxysmal nocturnal dyspnea, and we talk about that more as well. So pulmonary edema, pink frothy sputum, crackles in the lower base lobes. Okay, yeah, this bad, or difficulty breathing. Take your pick. So anyway, we've already got that. Here's what your PCWP is going to look like, your wedge. Okay, so we see our diastolic, we see our diastolic, systolic, diastolic, systolic, diastolic. And this is our pulmonary artery, and this is what's going to look like before I inflate the balloon. Okay. So then I inflate the balloon. Boop. See it? Okay. All right. The doc's going to say, hey, I want, wedge pressures every so often, or hey, I want them PRN. I'm going to tell you when I want them, or, and normally they're a set of intervals. Okay. So the doc says, hey, all right, what's my pulmonary artery pressure? And you're going to say, hey, doc, we're sitting around 25, 30 systolic, whatever, 20, whatever case, whatever's showing you. Okay. And then you're going to inflate that balloon. And now we're getting our wedges. And here is my peak wedge right there. Right there. You can see that falls down into about close to 10, 12. And that's where I want it, 6 to 12. Okay. And again, if it's increased, you need to know the indications of what increased wedge pressures, not indications, excuse me. You need to know the causation of increased wedge pressures, and you need to know the causation of decreased wedge. Okay. Increased wedge, what's going to result in? Left ventricular failure, caused by left ventricular failure or fluid overload, decreased PCW, or excuse me, wedge, hypovolemia, hemorrhage, dehydration, cardiac tamponade potentially for either one, but typically cardiac tamponade will result in an increase in wedge. Insertion sites, we've already talked about this. And I'm going to move past that, and there's that chest x-ray I talked about earlier. You see them float the Swan-Ganz catheter, and you can see it even coming in over here. Look at it, right there. He's doing some claving here. We're going to go down. Superior vena cava, that's where we are. Okay, drop into the heart right here. Boop, boop. There, this is the atria. There's the ventricle. We floated back up, pulmonary artery. Ta-da! And we're where we need to be. So that chest x-ray shows it very clearly. And there's other ways you can get imaging to see that. You definitely see it on an MRI, but that's we don't do MRIs to verify placement. It's going to be a chest x-ray, okay? Or even an angiography could detect that. Anyway, so the other thing that we can do to detect placement is look at our wave. Okay, we can look at our correct waveforms, make sure that, and I showed you this image earlier. I'm going to just peek back to it real quick. This is what our waveforms look like as we're moving through the different anatomical structures of the heart and eventually into what is the pulmonary artery. Okay, so same thing, transducer level. Pressure readings always be taken at end expiration. Okay, clinicians should rely on more on the waveform rather than digital display. That's 100% true, because if you have a digital display that says, or it's giving you a number, for example, like I'm getting a wedge, my wedge says 1 or 2. Well, I know that's incredibly low, and I may have a very serious problem. But if I look up at my waveform is dampened or flattened out and doesn't quite look correct, then I'm going to indicate, or that indicates to me that I probably don't have an accurate representation of what the pressure actually is. In that case, and it's not your responsibility to advance, to move, to manipulate. Okay, but the physician's going to say, hey, here's what I have. When I do my wedges, I get a pressure of 1. I get a pressure of 2. Okay, and the physician's going to be like, okay, well, what's the waveform look like? And you're saying, well, it's dampened, it's restricted. And then from there may be a need for a chest x-ray and further advancement to make sure it's in the right place, or even pull back a little bit. Okay, so just be aware of that. Lastly, alterations in mechanically ventilated patients due to increased pressure. That's a big one. I think a lot of people forget the minute we introduce any kind of positive pressure ventilation, and I don't mean just vented patients. I mean patients that have any form of positive pressure coming into them, whether it's CPAP, BiPAP, bag valve mask, or in this case, a mechanical ventilator, you have increased thoracic pressure due to the volume and pressure being asserted by the machine. When you have that, and keep this in mind, the more pressure asserted at the alveolar level, the more stress and pressure is placed on the capillary beds. The more stress and pressure on the capillary beds puts pressure on greater vessels, including your pulmonary arteries and subsequently your vena cava as well, in a very passive manner. So you actually can get bradycardia and hypotension secondary to mechanical ventilation and positive pressure airway management. So just be aware of that. We already know these. We don't know those yet, but we'll talk about them. We know these though. Okay. There is other ways we can monitor a lot of these hemodynamic values. There are cool machines. St. Mary's has a couple of them, so does San Antonio. The ClearSight system is one such example of a machine. It's made by Edward Life Sciences. We have 2 at St. Mary's. I know we're phasing them out in favor of a newer, more accurate system. But really, all it looks like an SpO2 monitor. We tack it onto their finger, and it can actually calculate certain values. And not all. I can't get a wedge pressure here. But I can get like cardiac output index, stroke volume assessments, systemic vascular values. I can get MAF. I can get all sorts of stuff based off this. And then if you put it in conjunction with, say, like a central line, you can get even more values. So, but most of that is actually calculated through formulas in the machine. Like obviously, I cannot get a dead-on to the milliliter calculation on my cardiac output, but I can get some pretty accurate estimations based on the values this machine assesses. I'm not going to talk about that. I will talk about this. So when we talk about the SpO2, we're talking about consumption, oxygen demand versus oxygen consumption, the difference between oxygen delivered by the arterial system and the amount returned to the heart by the venous system. And this is where we get these mixed blood gases. Okay, and we've talked about that too and their value and importance. I'm going to expand on them a little more here. But essentially what we're looking at is the arterial system brings in deoxygenated blood to the pulmonary vasculature, okay, or is part of the pulmonary vasculature, brings it to the lungs, deoxygenate it, we reoxygenate it, and bring it back to the heart, okay? But what if I wanted to measure how much oxygen I have in one and how much oxygen I have in, so in other words, what is my oxygen concentration, CO2 concentrations prior to going to the lungs, and what are they after I go to the lungs, okay? So you must know your normal SvO2 is about 70%, okay? And your ScVO2 is typically going to be slightly higher, 75 to 80%, just a little bit, okay? We do have the ability to venous blood sample, okay? And this is a older image, but essentially all we're doing is we have a mixed blood gas access where we have pulmonary and venous blood mixing together in those capillaries, and we're able to extract it, take a sample of it, and actually measure both venous and mixed and see the amount of concentration in the venous blood in terms of carbon dioxide, oxygen, and even bicarb. Okay, I'm gonna put this in there real quick for you. I want to discuss it. We've talked about arterial blood samples or ABGs, arterial blood gases. We also do the same thing with VBGs, or venous blood gases, but they have different values, obviously. So my pH on my arterial blood gas should be 7.35 to 7.45. My CO2 value should be 35 to 45, and that's this right here is where CO2 would be. My apologies. Oh, hey, look, there it is. My apologies. And then our O2 value, PaO2, would be 80 to 100. Okay, bicarb 22 to 27, and that's arterial. Venous, on the other hand, we're a little bit lower because we have some more carbon dioxide. Ionically speaking, our pH has dropped, a little bit more acidic, 7.32 to 7.42. Carbon dioxide concentrations will absolutely be more elevated, 41 to 51. Not by much, but they're elevated. So, and then what we're actually looking at is, hey, look how much oxygen's here, 30 to 55. Look at these correlating, so there's this misconception that blood returning to the heart via the vena cava, blood returning or going to the lungs is deoxygenated, all of it. And that's not even kind of true, not even a little bit. What is true is we do have a almost one-to-one mixture of carbon dioxide and oxygenation. Okay, so yeah, is the bulk of your blood coming back to the heart, or sorry, does the blood coming back to the heart going to the lungs, does it have a lot more carbon dioxide in it? Yeah, it does. But what it really has is far less oxygenated blood. And that's where we go into the lungs, we go into the alveolar bases, the capillary beds there, boom, we reoxygenate, come back to the left side of the heart and eject that into the body. And that's that arterial value that we'd be sampling. Okay, but venous, I do need you to know these numbers. I do need you to know the difference. Catheter care for any catheter, period. I'll go over that. Site care and dressing changes, absolutely. So once every 7 days is the recommended dressing change interval for any central line. Obviously, we changed them PRN for any kind of soiling, a break in the sterility or the sterile field, any kind of tear for any reason. Okay, or maybe we were just manipulating the line. Maybe I had to advance it. Maybe I had to pull it back. We're not talking about a swan gans here. Okay, but if I move that dressing off, I'm just going to redress it, sterilize and redress. We don't want central line infections. Okay, and I know you guys have, I guarantee you've discussed CLABSI and CAUTI in the past, and that's that central line. CLABSI is that central line acquired blood infection or infection in general, and that can lead directly to a state of sepsis. We don't want that. How do we avoid it? We care for the site appropriately. Change your lines, flush your solutions per protocol. Each hospital is different. But again, this is more of a learn on the job kind of thing. Ensure tight connections, absolutely. Do not leave them open unnecessarily. Do not inject any fluids. Don't use dirty syringes. Don't use any of that. Always use sterile contents. Okay. Monitor for dysrhythmias whenever you're manipulating any of these lines. During the insertion of a central line, absolutely. During the insertion of an arterial line, not even closely as common, but it is possible, technically. During Swan-Ganz insertion, absolutely. During any central line or Swan-Ganz, you're going to be on continuous, well, I shouldn't say during any central line, that's not true, but you're probably going to be on some kind of cardiac monitoring for the duration of the procedure. Now, the Swan-Ganz, you absolutely will be on ECG monitoring. You still can insert peripheral, like PICC lines, for example, still central line, okay, peripherally inserted central catheter, but you're not always going to be on cardiac monitoring unless your hospital indicates it. Okay. I personally like to have cardiac monitoring purely because when you tickle that right atria or advance it a little too much and you tickle the bottom there where the tricuspid valve is, you can cause some dysrhythmic rhythms. And you could technically advance it past the right atria into the right ventricle, and then you get a whole lot of tickle tickle and that electrical funky boogie dance that the heart does, and that's called a dysrhythmia as well. We don't like that. We're going to monitor our flush. We're going to flush regularly. I like to flush at all of my assessments, not a long one, just a brief flush. Make sure my waveform's good. Okay, everything's zeroed, leveled. All right, sweet. No kinked, bent tubings, no catheters that are kinked or bent. Everything's good. Avoid interventions that may introduce air. Absolutely. And now, there's this misconception that like, oh my God, hey, look, an air bubble, you're going to die. That's not the case. It would take roughly about, in most patients, not all, a continuous stream of about 8 to 15 mLs minimum to create cardiac disturbance. That's a lot. It's like taking a flush and just slamming it. That's a lot. I am not telling you to test this. I'm not telling you to go do that. And yes, there have been cases where it took less than 8 mLs to create a PE, an air embolus. Okay. I'm just making you aware of the fact that if you see some baby air bubbles in the line, do not panic. Do not freak out. If you see large sections of air bubbles, yes, those need to come out. Absolutely. Okay. Monitor your waveforms all the time. All right. Really quick, we can pull back on central lines, and typically it's not us that do it even, and we can. And typically we don't just pull back because we think it's too far. We have to do imaging, chest x-ray, verify placement. Radiologist says, yeah, you know what? That catheter is a smidge deep. We need to pull back on it. Okay, well, how far should we pull back? 2 centimeters. Let's bring it back 2 centimeters, and that's about just a little under an inch, about 4/5 of an inch. Okay, so all right, let's pull all back on that. All right, and then you're gonna take your dressing off. There's markings on the actual catheter showing you where. And then all right, 2 centimeters back, okay, or 20 millimeters, whichever comes first. 20 millimeters. And then we're gonna pull it back and boom, we're where we wanna be in place. Okay. And that's pretty much it. I could go over patient assessment, but honestly, it's stuff you guys already know. Um, Always have a baseline. And remember, we're not using these devices to establish baselines every time. We establish the baseline when we insert these things. I establish the CVP base. I establish my arterial line base, my Swan-Ganz and wedge pressure bases, pulmonary artery pressure bases. We then trend from that point on. And the trending tells us what the patient either needs, what they may have too much of, too little of, maybe their pressures are too high, they need to be managed medically with some medications. Okay, there's a lot of stuff we do, and that's where that trending comes into play. We're not just trending the numbers, we're trending the waveforms too. Okay, and then what we do is we mirror these, we compare these to our current diagnosis and to the current state of the patient, and we monitor and watch how they progress. So overall, that's all I have for you today. That is our lecture number 1. I hope this helped you guys, and you all have a fantastic day. If you have any questions, as always, feel free to reach out to me. You guys take care.